everyone. So welcome to OT and Bay. And if you're anything like me, you've probably opened the burns chapters before, looked at four different, burn classifications, burn phases, positioning, graph, scar management, and immediately closed the book. I remember thinking there's absolutely no way I'm going to memorize all of this, but here's what I eventually realized. So burns actually isn't difficult. It's just usually taught in a way that, makes it feel overwhelming. So today I'm going to show you exactly how I organized this topic while I was studying for the NBCOT. We're going to simplify everything into visual concepts that actually make sense. So grab a coffee, grab your notebook, and let's study together. So let's start with a patient. Imagine you're an occupational therapist working in an acute burn unit. Your patient is a 42-year-old man who sustained burns after a house fire. Before we talk about treatment, before we talk about splints, before we even talk about occupational therapy, I want you to ask yourself one question. What do I actually need to know about this burn? Believe it or not, everything starts with understanding one thing. How deep is the burn? So by the end of today's session, you'll know exactly how to answer that. Before we memorize first degree, second degree, third degree, let's zoom out. Instead of thinking I have four different burns to memorize, I want you to think I have one concept to understand. Burns are classified by depth. And once you understand the depth, you can predict almost everything else. How long it takes to heal, whether it scars, whether skin grafting is likely, how painful it is, what OT should prioritize. So instead of memorizing four separate lists, we're going to follow one simple trend. So what exactly is a burn? A burn is an injury to the skin and sometimes even the tissues underneath, right? There are several different ways burns can happen. It can happen through heat, chemicals, electricity, radiation, and even friction. But here is something really important. We don't classify burns based on what caused them. Instead, we classify them based on how deeply the tissue has been damaged. And that's the key idea I want you to remember here. Now, meet today's study buddy, Toasty. Yay! So you're going to see this little guide throughout the lessons because I wanted something that would, make difficult concepts easier to remember. And for burns, Toasty is absolutely perfect. As the burn gets deeper, Toasty gets more toasted, right? I know it's silly, but that's actually the point. Our brains remember stories and images much better than randomness. So every time you see Toasty getting darker, I want your brain to immediately think deeper burn. And if it's a deeper burn, what happens? Healing takes longer, scarring becomes more likely, sensation changes, OT intervention becomes more complex. One picture helps you remember four different concepts. So let's talk about first degree burns. These are also called superficial burns because, they only affect the epidermis, which is the outermost layer of the skin. A really common example is a mild sunburn. The skin looks red, it hurts, but you won't see blisters. Now, here's something students sometimes overlook. Even though this is the least severe burn, it can actually be very painful. Why? Because all of the nerve endings are still intact, right? Nothing has destroyed them. So when you touch the skin, those nerves are still sending pain signals to the brain. The good news is that healing usually happens within several days without significant scarring. And now let's go over to the second degree burn right here. So we have partial thickness burns, also known as second degree burns, and this is where many students start getting confused because second degree burns are actually divided into two different types, superficial partial thickness and deep partial thickness. Instead of memorizing two separate definitions, think about how much of the dermis is involved. The deeper the burn extends into the dermis, the longer it takes to heal. So let's talk about the superficial partial thickness first. So this type extends into upper dermis because many skin structures are still healthy healing can usually happen on its own. You'll often see blisters, moist wound bed, pink or red appearance, significant pain, and again, lots of pain because many nerve endings are still functioning. But now we are damaging much more of the dermis here. So healing becomes much slower here, scarring becomes much more likely, and depending on how deep the injury is, skin grafting may be necessary. I don't want you to memorize healing times for every burn, but instead remember this question. Is enough healthy skin left to regenerate on its own? If the answer is yes, then healing is generally faster. If the answer is no, healing becomes slower, scarring increases, and grafting becomes much more likely. So NBCOT questions often reward this type of reasoning rather than, memorizations. So far we've learned what burn is, why burns are classified by depth, first degree burns, second degree burns, and hopefully Toasty is getting a little toastier in your mind. And now, before we move on, I want to ask you something. So without looking at the notes, which one do you think has the highest chance of healing on its own? Pause for a second. The answer is our lightly toasted friends, because they still have enough healthy skin left to regenerate, right? So now let's see what happens when we keep turning up the toaster. Okay, so third degree burns are also called full thickness burns, and this means the burn has destroyed both the epidermis and the entire dermis. At this point, there isn't enough healthy skin left to regenerate normally. So let's think about what we've lost. Hair follicles, gone. Sweat glands, gone. Oil glands, gone. Most importantly, many of the nerve endings have also been destroyed here. So this is probably one of the most commonly tested concepts. Students often think the worse the burn, the worse the pain. That sounds logical, but it isn't always true. Then remember our first degree burn, it hurt because all of the nerves are still working. By the time you reach a full thickness burn, many of those nerves have been destroyed, right? So the burn itself may actually have little or no sensation. Now, that does not mean the patient isn't experiencing pain overall. Burn patients often have pain from surrounding tissues, procedures, dressing changes, donor sites, or areas with partial thickness burns. For the NBCOT, the key point is that the full thickness burn itself may have reduced sensation because the nerve endings are damaged. So what does a third degree burn actually look like? Instead of being bright red and moist, it often looks dry, a little leathery, waxy, white, brown, or even charred black. That's because the tissue has been destroyed, right? And because we've lost the skin's ability to regenerate, these burns usually do not heal well on their own. Most patients require skin grafting to close the wound. Our poor Toasty is definitely looking overcooked now. Now let's go one step deeper. So the fourth degree burns don't stop at the skin, right? They continue into deeper structures like muscle, tendons, and even bone. This type of burn is often associated with severe thermal injuries or high voltage electrical injuries. Because these deeper, tissues are involved, the injury becomes much more complex. The tissue is often completely charred like this, and there is little to no sensation, and these injuries almost always require surgical management. The NBCOT usually isn't asking you to memorize every detail about fourth degree burns, but instead they're testing whether you understand that the deeper the injury, the more complicated the rehab becomes. So now let's stop memorizing individual burns, but instead look for the trend. This one pattern predicts almost everything. So the burn gets deeper, healing takes longer, scarring increases, the likelihood of grafting increases, functional challenges become greater, and sensation decreases because more nerve endings are damaged. So you might be wondering, okay, but why does any of this matter for occupational therapy? Great question. Because burn depth tells us what rehab might look like. right? A first-degree burn, maybe some education and symptom management. A superficial partial thickness burn, protect the wound while maintaining function. A full thickness burn, now we're thinking about graft protection, positioning, splinting, scar management, range of motion, and eventually helping the client return to meaningful occupations. So understanding burn depth helps us what the client may need, not just medically, but also functionally. So now let's see if you got it. Which burn is most likely to require skin grafting? First degree, superficial partial, deep partial thickness, or full thickness? Take a second to think. And the best answer is the full thickness. So because the entire epidermis and dermis have been destroyed, there isn't enough healthy skin left to regenerate on its own, right? So now, depending on the depth and wound characteristics, deep partial thickness burns may also require grafting, which is why they're important to recognize. But if the question asks for the most likely answer, full thickness burns are the classic choice. So before we move on, let's check in with Toasty. So light Toasty, quick healing, minimal scarring, very painful, and dark Toasty, long healing, more scarring, less sensation, and lots more OT intervention or involvement. See, you just learned 4 burn classification without memorizing 4 separate tables. So now that we understand what the burn is, the next question becomes, what do we actually do as an occupational therapist, right? That's where burn phases, positioning, splinting, and early intervention comes in. So let's head over to our next page. So now we know what kind of burn our client has. But here's the next question. What should we actually do as OT, right? Believe it or not, the answer depends less on the diagnosis and more on where the client is in their recovery. That's why understanding the burn phases is so important. Let's go back to our patient from earlier. So he's been admitted after a house fire. He has deep partial thickness burns on both upper extremities. Now ask yourself, should OT immediately start strengthening exercises? Probably not, right? Should we fabricate a splint on day 1? Maybe. Should we focus on survival first? Absolutely, right? Let's see why. So instead of memorizing 3 phases, I want you to remember one question. What is the biggest priority right now? Every phase has a different answer. So let's start with the emergent phase. So this begins immediately after the burn injury and typically lasts until the client is medically stabilized. So at this stage, our goal isn't independence. It isn't ADLs. It is not strengthening. It's much simpler than that. Our goal is keep the client alive. So let's start with the airway. So one thing people don't realize is that burns aren't just injuries to the skin. If someone was trapped in a house fire, they may have inhaled hot air or smoke, right? That heat can cause swelling inside the airway, even if the skin burns don't look terrible. The airway can continue swelling over the next several hours. That's why airway management is always the first priority. Next comes the breathing. So if someone has burns around the chest, especially circumferential burns, the burn skin becomes stiff. So imagine wrapping your chest with a tight leather belt. Every breath becomes harder.
In severe cases, an escharotomy may be performed to release that tight burn tissue so the chest can expand again.
And now let's talk about the circulation. So this is one of those concepts that's easier to understand than memorize. So after a major burn, the tiny blood vessels become leaky, right? Instead of keeping fluid inside the bloodstream, that fluid starts leaking into the surrounding tissues. So the patient becomes swollen and while at the same time losing circulating blood volume. That's why severe burn patients, that's why they need aggressive fluid resuscitation early on. So finally, the infection. So healthy skin is one of our body's biggest protective barriers, right? When the barrier is destroyed, Bacteria have a much easier time entering the body, and that's why wound care, sterile dressing changes, and infection prevention are so critical during this phase. So here's something I want you to remember for the exam. So if the client is still unstable, OT goals are not about improving handwriting or cooking skills, obviously, right? And at this stage, our role here is supportive, right? Positioning, edema management, protecting range of motion when medically appropriate, and preventing future complications. So let's now go over to the acute phase. So once the client becomes medically stable, our priorities begin to shift, right? Now we're asking, how do we heal this wound? This is the acute phase. So the biggest goals here are close the wound, prevent infection, protect any grafts, and begin rehab safely. So I also want to briefly explain skin grafts because students often mix these up. An autograft comes from the patient's own body. Since it's their own tissue, it's considered permanent. An allograft comes from another human donor. A xenograft comes from another species and most commonly a pig skin. These are usually temporary biological coverings that are used to protect the wound until definitive treatment can be performed. So this is probably my favorite part of the burns. So many people assume OT begins after everything has healed, but that's actually not true. OT begins very early. Why? Because contractures don't wait. Scar tissue begins organizing almost immediately during healing. If we wait until the scar has fully formed, we've already lost our valuable time, right? So let's start with the positioning. One sentence. That's all I want you to remember. Comfort is the enemy of function. I know this sounds kind of mean, but let me explain. So person lying comfortably, right? Arm bent and scar heals like this. Arm gets stuck. When we get comfortable, our joints naturally fall into flexion. Elbows bend, shoulders adduct, necks flex, and unfortunately, scar tissue loves shortened positions. As scar mature, they naturally contract. If the joint stays flexed while healing, it becomes much harder to regain full motion later. Right, so as OTs, we often position clients in anti-contracture positions. These are not always the most comfortable positions, but they're the best positions for preserving long-term functions. So sometimes positioning alone isn't enough. That's where splints come in. Splints help maintain joints in anti-deformity positions, especially during rest, sleep, or after skin grafting when movement needs to be carefully controlled, right? And also, students often ask if movement is important. Why are we splinting? Great question. The answer is balance. During periods of rest, we protect the tissues. During therapy, we move them. So, burn rehab is a constant balance between protection and mobility. So, our goal is always to encourage movement as early as it's medically safe. Active active range of motion if possible, active assisted when needed, and passive range only when appropriate. And because therapy can be very painful, sessions are often scheduled after pain medication to maximize participation. Remember, the goal isn't just ROM, the goal is functional ROM, right? We're preserving movement today so our client can dress, cook, work, and return to meaningful occupations later. Now let's talk about edema. So one of the biggest problems after burns is swelling. And fortunately, the treatment principles are very simple: elevation, compression, exercise. Those three interventions work together to reduce edema and improve function. And as wounds continue healing, our focus shifts again. So now we're managing scar tissue. Scar massage when appropriate, compression garments, stretching, functional use. Scar management isn't just about appearance, it's about preserving movement and helping the client participate in everyday life. So let's go back to our patient one last time. He's medically stable now, so his graft is healing well. And today you notice he's resting with both elbows bent because it's more comfortable. SDOT, what's your biggest concern? Right, the biggest concern is contracture formation. That's why positioning, splinting, and early range of motion are so important during the burn rehab. So before we finish, let's summarize everything we've learned. So burn depth predicts healing, burn phase predicts your priorities, and OT starts early, positioning prevents contractures, movement preserves function, and every intervention should help the client return to meaningful occupations. And that's burns. If this lesson helped make burns feel just a little less overwhelming, I'd love to know in the comments what topic you'd like to see next. I'm slowly turning every NBCOT topic into visual notes and concept first lessons. So if you like to study along with me, don't forget to subscribe and follow me on my Instagram or TikTok. And remember, grab a coffee, learn one concept at a time. You've got this. Study hard, pass hard. I'll see you in the next note. Bye.